you can still hear me okay?
I hear you perfectly, yep.
Great. Well, once you have the presentation up and going, I just want to thank everyone for joining in. I'm going to be quiet very quickly, hand it over to Rob to go through the presentation. The one logistic thing is, as Rob goes through his presentation, if you could please type in any of your questions, we'll be able to see them on our end, and then we'll be able to moderate a Q&A for Rob as he finishes it. So, Rob, I'll hand it over to you.
Okay, great. Hey, guys, I'm really sorry for all that, but I'm glad we're here. We're going to get down to this and figure it out really quickly. A quick description of what my practice is all about. I'm a sports medicine-based doc. Been doing this for 25 years. I'm in a suburb of New York called Orangeburg, New York. My practice deals with mostly overuse injuries. I follow the Dr. George Sheehan method of all the patients are treated as an athlete. We're just in different levels of competition or different levels of training. I like to utilize a tier approach in my dealing with my patients, and we start with the most conservative and work our way up. And I like to involve the patient in the plan of everything that we possibly do. I think that an informed patient is your best patient. Next. Next slide.
Yep. Next slide. What made me interested in Tenex?
Oh, got it. Yep. All right. So what made me interested in Tenex? I'm sorry. So I always, in my practice, I tell my residents that come to see me, I say we want to know, what it is, but more importantly than knowing what it is, we want to know why it is. So I want to get to that root cause of the injury, what's going on there. And we know most of these, injuries that we see, they're refractory type of injuries, and are we dealing with an itis like tendonitis or fasciitis, or we're dealing really with an osis, fasciosis or tendinosis. So I found out that the Tenex mode, it definitely involves that a little bit more, and more importantly to me, it keeps my patients moving. I think that's really important in my practice. When we're dealing with athletes, they don't want to be slowed down for any reason whatsoever, so they want to keep going as much as possible. Now, some of the other things that really, made me interested in Tenex is that, it's a reimbursable procedure, so it's good for your bottom line, and the minimal downtime that the patient has is really, so important. Next slide. Current experience. I'd say I probably have close to 100 of these procedures down under my belt right now. I do all of them at a surgical center or at a hospital-based setting. I do give the patients anesthesia when I do it, local anesthesia with a MAC. As far as complications or patients that haven't worked out so well, I say out of all the patients I've done, I've had one individual who did not turn out exactly the way I wanted to see. They didn't get any worse, obviously, but they only got minimally better. And I think probably it was more of my error in the fact that I misdiagnosed this patient. The patient was also a diabetic who had some neuropathy. So I think it was probably an overuse injury. Is more a neuropathic issue. Next slide. So what's the problem? We know that what we're dealing with here is an overuse injury. We talked about the osis as opposed to the itises. These things are not inflammatory problems. So the things that we usually try to utilize for inflammatory problems like anti-inflammatories and cortisone injections and ice just don't work. And if anything, some of the underwhelming treatments like cortisone mask the pain. It can actually make things worse as time goes on. So the solution was to come up with something that was a minimally invasive manner using an ultrasound guided system using a TX probe. So it replicates surgery, but without all the other issues that you have with it. Next, the burden of disease, as you can see, plantar fasciitis has definitely become an epidemic, to be quite honest. We see out of 20 million patients per year, 3 million patients have plantar fasciitis, and about 5.5 million patients have Achilles tendonitis. I think you can have a practice just based on those two diagnoses alone. Next. So here was where the unmet clinical need was found. We said with the conservative care we dealt with was rest, ice, over-the-counter medications. I was actually at a physical therapy center today talking about TX procedure today, and there's still a need for physical therapy, but when the patients come along and they're no longer doing well, and they don't want to go to the fully invasive open type surgery because of the problems of rehab and a long recovery, and we talked about cortisone, it's just not really cutting it anymore. that's where the TX system works perfectly well for these patients. It's the perfect little spot for them. It's one treatment. You get local anesthetic. You're actually removing the source of the pain. So these patients do really well with this minimally invasive yet definitive treatment. Next. Once again, you said you can have a practice just based on plantar fasciitis and Achilles tendonitis. 25% of the foot visits come in out of the 25,000 patients that have been treated since 2012 have been plantar fasciitis. I'd have to say in my practice, I probably see even more. 40% of my patients that come into my door have plantar fasciitis, while close to 20% have Achilles injuries, and 10% of those people are runners as well. Next. So here's the Tenex TX system. Basically, it's a console and a micro-tip. The console, uses precise circuitry, and it targets diseased tissue while sparing a healthy tissue. And the micro-tip is basically, it's like a pen or an 18-gauge needle that's in your hand. And as practitioners, I'm sure you use ultrasound and are very adept at giving injections over the years. So it becomes very intuitive for us to do this as time goes on. What you utilize, there's a pre-assembled foot pedal that goes along with the TX system. Everything is single use and entirely disposable. Next. Here's the technology. This is what's really cool about it. This just at the very tip of that probe, the TX probe, you have this area that moves back and forth, kind of like a jackhammer. And through that, you get ultrasonic energy that comes through there. And what's really nice is that because of the harmonic resonance that is utilized by the TX probe, only bad tissue, only the negative or fibrotic tissue or diseased tissue is being cut, which is great. And the healthy tissue it stays elastic and it's fine. And while this is going on, through that area, there's a continuous saline irrigation that cools everything. What's kind of cool about doing this when you do the procedure, you can actually see little fragments of this necrotic tissue that gets pulled out into your collection sample. So definitely removal of all that targeted tissue is really important. Next. So as far as patient selection, I usually like to get patients that have been dealing with this issue for at least 3 months. The problem with that is that most of the patients that enter our doors have probably had this for much longer than 3 months. They're the patients that come in with a bag of things, with orthotics and Dr. Scholl's and sneakers, and they're the bag people that walk into your office. So they're looking for something new. So they've probably already met that criteria, being over 3 months. They have to have point tenderness. Usually they can. I always ask them point with one finger where it hurts the most, and they'll point right to that spot. I usually mark that spot right then and there, and then we use ultrasound to confirm it. What's really kind of nice about that is that patients, especially athletic patients, love to see themselves. So it's a great marketing tool as well to use ultrasound, because they actually can understand what's going on, what they'll see, and you'll show them. You'll see a thickened area of tissue, and it'll be a hypoechoic area, a darker area that looks irregular and disorganized. The fibers don't look as organized as the regular collagen fibers that you see in other areas. Next. As far as the placement of these patients, usually put them in for Achilles tendinosis, and you're able to be able to see their, in prone position, you're able to see their Achilles looking right at you. You're able to take that transducer, and as you see in this slide on the left, you can put it into the sagittal transverse plane. And what you see on the right-hand upper side of the frame, you see a organized, healthy tissue with the collagen fibers organized perfectly. When you have damaged tissue, you can see that hypoechoic area looks blackened, thickened, and just not the way it should look. And patients really appreciate that right away when they see that. Next. The plantar fasciitis, very similar. You can put them in the prone position as well. There you see where the transducer goes a little bit more to the medial aspect of the midline. Once again, you can see where the tissue is enlarged and disorganized. You can usually tell them that a normal plantar fascia is about 2.5 to 4 millimeters, but in the damaged state, it can be 2 or 3 times the size of that. And once they see that, and you push on that spot in real time using the diagnostic ultrasound, they usually have this aha moment, and the procedure kind of sells itself from doing that. Next, here you just see once again the Achilles tendon preparing for the procedure. You can see the transducer is covered with a sterile sheath. And then next, as we go to the next slide, you can actually see where the through a small stab incision, the TX probe is put in through the tendon, and the hypoechoic area is focused upon, and we start to clean that area out. And you can actually see changes as you start doing this over a period of 1 to 2 minutes. Next slide. In the plantar fascia, same thing. You put your probe. You usually start off in one clinical direction, using the sagittal plane, and then you can switch to transverse. And you can see your TX probe tip coming into that area and able to clean out the area that's hypoechoic. Next, here's just showing you how you do it. You mark it, you prep and drape, use your 11 blade, make a stab incision into the medial aspect of the plantar aspect of the foot. You inject that area. Next, and then you stick your probe medially, and you move your transducer from sagittal to transverse, keeping the probe in line with the transducer head. And to be quite honest, if you're doing diagnostic ultrasound already, this is really easy. If you haven't done it, there's a little bit of a learning curve because you're using 2 hands and looking at a screen. But I'd be quite honest, it's a quick learning curve, and as you do more and more of these, you'll realize how really simple the procedure is. It's a great procedure. Next, there you can see the micro-tip placement in a plantar fascia, once again, coming in from right to left. Excuse me. Next. Okay. Excuse me. So it's a very cost-effective and well-tolerated. What's really nice about it, there's no restrictions before the procedure, so if the patient was running, 25 miles a week, they can continue to do that up until the procedure. The total time of the procedure, you tell the patient, is only about 20 minutes. There's no pain or discomfort during the procedure, even if you're not using, if you're using general anesthesia, or if you're using Versed, or if you're just using local, they're not going to feel anything. They go home right afterwards. This says no PT. I personally do use PT, and I'll talk about that a little bit in the future. I give them over-the-counter pain meds, usually consisting of just Tylenol or extra-strength Tylenol. I tell them to take it easy for a few days and go from there. Excuse me, next slide. What I usually do is I send them home in a cam walker, cam boot. I tell them, minimal ambulation for the first 2 days in the cam boot. If it's, for both procedures, if it's for Achilles or for plantar fascia. I have them return to the office in 2 days for a dressing change. I tell them to remain in the cam walker for, if it's plantar fasciitis, for about a week's time. If it's for Achilles tendonitis, I have them stay in it for about 2 weeks' time. And I personally begin PT, physical therapist, when they come out of the cam walker. And my reasoning behind that is that, yeah, we're getting rid of the pain and the patient feels a lot better, but I find that the patient has inherent weakness due to the fact that they've been guarding this area for such a long period of time. So I think the physical therapy does help them. It also helps in the fact that the therapist, if you train your therapist properly, they will massage that area, deep friction massage that area, mobilize that tissue a little bit more, because the patient might be a little bit tentative about doing those things. It just gets them up and moving a lot more quickly, and I find that it's a great practice builder as well, because you're involving your physical therapist. You're not getting them out of the loop. They're telling their other patients about it. They love the fact that the patients get better right away, because listen, they're dealing with physical therapy. They're dealing with plantar fascia and Achilles tendon patients that are recalcitrant and refractory and just not getting better. So they love the fact that we can get them better, and they're part of the solution, which I think is really important. Next slide. So who not to treat and why? I stay away from vascularly compromised patients just because I don't want to deal with any other issues. This is an elective procedure, so we try to treat them with other modalities. The neuropathic patients, too, I'm a little tentative about treating them as well, just because, like I said earlier, sometimes the pain that they're having might not be truly biomechanical in nature. It could be neuropathic, and it's hard to tell which is which. And then I really try to stay away from, as you see in the bottom, my clumsy patients. I don't want patients who are going to cause new problems because they can't walk around in their cam walker afterwards. So I want to make sure that the patient understands what they have to do. And so I might stay away from patients who are very elderly in this situation, and they might not be able to walk around with a cam walker. Can't do it afterwards. Next. So how do you grow your Tenex practice? Well, first and foremost, if you're not using diagnostic ultrasound, you should. It's one of the largest growing diagnostic tools that we can use in our practice, especially if you have a sports-minded type practice. I think it's really important that you're able to show in real time to your athletic patients what's going on with their foot, and it helps them understand it a lot better and gets them more involved. Next, other ways to try to educate is that you got to get out there. You have to be the guy at the podium. You have to be able to educate not only your patients, but you have to educate your staff. They should understand what's going on. You have to educate your referral sources. Everyone you just get out there as much as possible, and before you know it, they're going to be calling you to do talks on TV because you got the latest and the greatest. There's other things in my practice I like to utilize as well. I use a message on hold. When patients are on hold, they can hear about what the Tenex procedure is all about. And I use an intake form when the patients come in. I give them an intake form if they have one of these pathologies, and I kind of see if they're interested in doing this before I even walk in the room. They might start checking the boxes off and say, "Wow, I really want to be part of this new modality that's going to help with my foot get better." Of course, we use brochures. I have it listed on my website, and I am really strongly utilize social media. I think that's a great strategy to get people out there. The Tenex team will really help you along the way with trying to get your message out there through the social media aspects, Facebook, Twitter, LinkedIn. They're very professionally done, and patients very much respond to that, especially our younger population. That's how they communicate nowadays, and that's how you want to get the message out there. So that's it. I'm going to leave it up to some questions and see what you guys have to say.
Perfect. Rob, first of all, this is Juggy. Can you hear me okay?
Sure can.
Perfect. Well, thank you again. As always, an exceptional presentation, and again, apologies for putting you on the spot with some of those technical difficulties in the beginning, but as always, you recovered magically. I have to say, looking at that last slide here, I think you're channeling your inner George Clooney with that TV spot that you had. So certainly I hope that worked out well for you.
It sure did.
Yeah. Let me throw some questions out to you that are coming in here and kind of get your response back. When you are first kind of describing this technology to your patients, what do you say?
So what I tell them is it's a newer procedure that's been developed by the Mayo Clinic that's used for chronic tendon injuries. So they understand that it's coming from a reputable institution. It's been time tested. It's been peer reviewed. And I tell them that it's something that we're trying to go not just for a quick fix, but we're trying to get to the root cause of the problem. And once they understand what the issue is all about, they're able to make a better decision. Too many times I think patients just come in and they say, well, I have a heel spur. They don't even know what that means because maybe their PCP told them that, or that's what they read on the internet. When you explain to the patient exactly what the issue is, and then you explain to them that there's a new technology that's available, they buy in right away.
Good, thank you. So I'll read a few more of these questions here, then we'll open it up. I don't use ultrasound in my practice. Should I consider using Tenex?
Yeah, I think if you did use ultrasound in your practice, it would help you that much more because of the reasons we stated earlier. But you still can use Tenex, even though you haven't used it in your practice. Your learning curve might be a little bit steeper at the beginning, but the more you do, the easier it gets.
Good, thank you. Talk about your experience in Achilles, both insertional and mid-substance.
With insertional, I personally have to tell you that I think Tenex works the best for my Achilles patients. Basically because the tissue is right there, it's easy to see. With insertional, especially when they have the osteophytes in those areas, these patients are hurting, and the procedures that were done in the past that are still available for us right now, they cause a lot of a lot of morbidity, and you want to get these patients moving. So I find that when I start utilizing the TX procedure for these patients, they are so happy. I had one gentleman, just to give you a quick anecdote, a gentleman who came in with pain in the back of his heel for years. He was one of the first patients I used the TX procedure on. Big 6'2", strapping Italian man with hands that would just go around my hand and crush me. And after I fixed him up doing the procedure, he came in and he was in tears. Honest to God, it really touched me. It humbled me. And he said, "You changed my life because you made such a difference. I'm able to walk and have no more pain." I also felt really good that I didn't hurt this big guy because I didn't want him chasing after me.
Yeah, the win-win, as they say. Good. What was your learning curve to get comfortable with the procedure?
So luckily, in my area here, our Tenex representative was able to bring in cadavers, and I was able to work in a cadaver course first, and understanding the process of how it works. And then when I went live on my first patient, I'd have to say, from the get-go, with the help of the representative and from going to and reading up online about the procedure, I felt pretty comfortable right off the bat. Maybe because I do give my injections through ultrasound. It seemed very intuitive, very simple. I think the one thing I learned is that at the beginning I was probably doing it more by feel and not understanding how to look at the ultrasound monitor as well. But as time went on, it works in harmony, and you're able to work it with each other, and works really easy. So I'd have to say, 1, 2, 3 cases, and you're up and running.
Good, thank you. Another question for you, Rob. Do you worry about Achilles tendon rupture, and what do you do to control for that?
I definitely worry about it every time we do any kind of procedure, even if you were just needling the area in the back there. Yeah, so what's nice about the TX probe is that you're not damaging the healthy tissue. You're only going against the fibrotic tissue. One of the things that I might do sometimes, especially if I have a patient that hurts in many different areas, I might make multiple portals. I might go from lateral and enter the area so I'm nowhere near the tendon instead of going through the mid-substance of the tendon. I might go lateral or medial to reach that area that causes the problem. And then what I do afterwards, like I said, I keep them in a cam boot for 2 weeks, especially if they're a bigger person. I don't want them to cause any undue damage to that area. But luckily, never a problem.
So I've got one more here before we open up the mics. How long does it take your Achilles tendon and plantar fascia patients time to feel better?
So it's really it's subjective to the individual. I've had patients who've come in and told me after the first 5 days that they feel 50% better, and I've had other patients that it might take 3 to 4 months until they feel 100% better. That being said, every one of the patients that have done well, with the exception of that one patient I told you earlier, feel better each passing week, and they're able to get back into the things they want to do really quickly. So I say on an average, I see a massive improvement within the first 2 weeks, and then I usually see complete resolution of issues within 3 months.
Awesome, good. Well, those are some very thoughtful questions from the group that were listening in. Nathan, what I'd like to do, and I'm sensitive to the time, I'd like to just, if we can, just open up the mics just for a few minutes and see if anyone has some questions specific to Dr. Conenello to close this webinar out.
Yeah.
Oh, great. Thank you. Starting to unmute everybody, so please be aware of that.
Yeah, so everybody now is unmuted. So if anyone has a question, please put it over to Dr. Conenello.
You might get another one. Okay.
Hello. Well, I'm interested, if you have a failure, what do you do if one isn't working? What is your next option?
Yeah, so if you have an individual where you do the procedure, that you're asking, and it doesn't work out, what do you do then?
Get another one.
Yes.
Please.
Yeah, so I guess the reality is that when is it a failure? So to me, I won't consider it a failure until I get to 6 months to a year. To be honest, I haven't improved except for that one patient, and you can offer the patient because it might have been a technical error, to be quite honest, where maybe I didn't reach the area well enough. But that is what I do offer the patient, is to do the procedure once again. But like I said, I also offer the patient physical therapy right afterwards, and we're still educating them on other things they have to do. So it usually doesn't get to the failure, to be quite honest. I think the 25,000 patients that have been done, and Jaggi, you could tell me if I'm wrong about this, I think it's a 90% success rate.
That's about right. That's what the clinical publications suggest, and then at least when we're out polling the community, we're sitting around that number. I think for everyone's benefit, the time to pain relief, at least on an average basis for foot and ankle, majority of patients will feel better within 3 to 4 months post-treatment. There is some in that kind of 5 plus or minus percentage that will take them up to 6 months to feel better. So that's kind of the distribution in terms of resolution of symptoms.
Another question might be, have you had complications? And if so, how do you deal with the complication of Tenex?
I personally have not had any complications, but there have been complications noted, including infection, and you treat that like you would treat any other infection, obviously. I'm not aware of any situations where there's been a tear of either the Achilles or the plantar fascia, but once again, you'd have to treat those accordingly as you would any other tear.
So on that, Rob, I'll share with the audience here. As you know, we were required to document any significant and serious adverse events, and we have, for everyone's benefit, had one, for disclosure, one Achilles tendon rupture. And that was in a patient that was on fluoroquinolone and had about 70% of their Achilles tendon that was identified as necrotic or hypoechoic under ultrasound inspection. That patient's tendon ruptured, I believe, 6 weeks post-treatment. So, that's one that we have, that we get some learning from, that at least the guidance is that there's significant amount of necrotic tissue, hypoechoic tissue. That's probably someone that's not ideal for the Tenex procedure. So there's been one out of, we're approaching 30,000 procedures now. There's one that we know of, I should say. Any other questions from the audience for Rob? Okay. Good. Well, Rob, first I'll just finish by saying 2 things. First, an apology to you, Rob, and an apology to the audience for the technical issues at the beginning. Rob, you obviously were able to master and rebound on that as you usually do. Thank you for a very elegant presentation. I thought it was very thoughtful and poignant, so I'll finish by thanking you and let everyone continue on with the evening and enjoy the day. So thank you again.
All right, thank you guys. Take care.
Bye-bye.